Hello, everyone. Welcome to the PMP Pals Hope Zoom call. It's good to see everybody. Thanks for being here. We have a large audience today, so I have muted all the lines as everyone comes in and gets settled and gets situated. We are super excited to have Dr. Melanie Ongchin from UPMC with us today. I know we're all excited to hear what she has to say about HIPEC today and the Pittsburgh program, one of our finest centers of excellence for sure. Great to see everybody. I'm still letting people into the room. And I say it every week. I'll say it again today. It's the highlight of my week. It's very good to see you all. Well, while people are coming in, I will go ahead and start to kick off the show. Give me just a minute to start to arrange my monitors and keep letting people in and move this all around while we do what we do. And I'm going to welcome everyone and say hello. Welcome to the PMP Pal Soap Zoom call again. We're so glad you're here. We're here every week, 3 weeks out of the month. We do a patient support call, and 1 week we do a physician call like today. And so again, we're super excited to have Dr. Ongchin from UPMC. I want to mention a couple things about what we do. We are not licensed physicians. We do have one here today, but we are not giving medical advice. You must make sure you have your own qualified licensed professionals for your care plan. Today, we have reviewed the presentation. You're not going to see things that are too scary. We think education is an important part of this journey, and you're going to be better for it. But do be aware you will see some of that information that could be scary to some. By participating in this forum, we may share your health information and your identity. We can't guarantee anonymity. Now, feel free to turn off your video and just listen in. And you can anonymize your name, but that can be technically difficult. So again, we can't guarantee it. We will be recording this video and sharing it with our pals around the world. And so you do grant your permission to share your likeness as we do that. Just some of the ground rules for this. It's a physician presentation. We will keep this to a hard stop at 90 minutes. So an hour and a half is the duration of the show today. We're super glad you're here. You stay here as much or as little as you want. If you have to go, don't feel bad. Go and enjoy your day. That's what we truly want. You recovering from appendix cancer and living life again. Feel free to use the chat function. We love seeing you sharing stories and encouraging one another. So feel free to do that throughout the show. And then stay connected with us throughout the week on the internet and Facebook and on Instagram. You see those addresses there. I'm really quick going to introduce the team. Just say hello. I'm Chris Piekarski. I'm the president of PMP Pals. Adele, would you like to say hello?
Sure. Adele Jason, the vice president of PMP Pals. And I feel especially honored since I had my surgery at UPMC that Dr. Ongchin is joining us today. So Adele, welcome everybody.
Thanks for reaching out to Dr. Ongchin too, Adele. Adele and I work hard to bring different physicians to the show. So thanks for doing that. Charmaine, I think I saw you join and there's too many people for me to scroll through and find you today, but I think I saw you join. Are you here?
I just got on, and good morning, everybody. Charmaine on the board, also here in Austin, Texas. Glad to see everybody.
Morning, good to see you. Thanks for being here. Wait, now how many years survival, Charmaine?
Oh yeah, 23 years. So 23 years ago.
23 years. Don't keep that number for me. I love hearing it every week.
All right.
Connie, I see you here. Would you say hello?
Good morning. Welcome everybody. My husband is a 5.5-year survivor. We're in Florida. Nice to see everyone.
And Connie is our caregiver extraordinaire. She's our quarterback. And so when we have new people join, you will receive your starter kits. You'll get your get well cards as we are here to support you through this journey. And she's the quarterback for that. So thanks, Connie, for all you do and for your advice for caregivers. I'm also going to introduce James Caldwell. James, would you like to say good morning?
Yep. Welcome, everyone. James Caldwell from Northern Ireland. I'm a 7-year survivor of a high-grade appendix cancer. I'm also an admin on the Facebook group.
And that's the PMP Appendix Cancer Facebook support group. We do endorse that Facebook page. And thank you, James, for your tireless work administering and facilitating that group. It's a place to get information. So thanks for being here. That's the team that I see today. Have I missed anyone, Adele? Did I get everybody?
Nope, I think
Good.
we've got everyone.
then we will jump right into the conversation with Dr. Melanie Ongchin. How are you today? Thank you so much for being here.
No, I appreciate it. And thank you, Adele, for thinking of me. And like I said, this is a wonderful organization. I think you guys are a huge part of what we do on a day-to-day basis. So happy to be here.
It's great. Well, so as we start to settle into the conversation, tell me, how did you get involved with HIPEC in your career? When did you become aware of this treatment modality, and when did you fall in love with it?
So I did my residency in Buffalo. So we do some of our rotations at Roswell Park, where I worked with John Skitsky, Dr. Kane, and that was really my first exposure to HIPEC, and I really enjoyed the patients and the procedures themselves. And then fortunately, I was able to match here at Pittsburgh for fellowship, where again it's sort of ingrained in the water that HIPEC is for everything. We can put chemo on something, we will put chemo on something, but it's really where you learn the nuances of the procedure, the patients, and you really develop a relationship with them. I then moved to Manhattan, where I was working at Cornell. I was actually tasked to start a HIPEC program there because they really didn't have a really robust program. So I really started a program there, and then most recently was recruited back to Pittsburgh about 1.5 years ago.
Terrific, terrific. And it's got to feel great as a physician to see patients with tumor burden like we see in this disease, and know that, hey, there's something we can do to help here. HIPEC is going to help this patient.
No, absolutely. And something that I really try to teach our trainees is, if we don't do surgery, what other options are there? And they are quite limited. And because of that, I think it's worthwhile having the discussion, number one, but also putting the effort into getting you guys to that point. And that's sort of the purpose of this talk.
Well, we're very grateful for the work that you do, and we believe that we deserve options, and we're very grateful for that and for the dedication that physicians like you show for us, because we know this is a big procedure. Well, why don't we talk more about that? Why don't I turn the table over to you, and you can share your presentation and walk us through and share your knowledge.
Perfect. So again, thank you for the invitation. Again, this is a huge support group for all of our patients, and it's definitely something necessary. So I just want to talk a little bit about CRS HIPEC, some of the indications, what to expect afterwards, but then the majority of the talk really talking about how to prepare for surgery, because no one really goes into the nitty-gritty on the details on that. So again, as far as peritoneal surface malignancies, in the past, when you carry that diagnosis, again, it was almost considered a pre-terminal condition. And patients, like Chris had just mentioned, had no options. They basically had palliative surgery, palliative chemo, or hospice. And we've obviously come quite a long way, you guys being the survivors of all this, but really showing with advances in both medical and surgical care, we now really have learned how to combine chemotherapy and how we manage surgery to really get patients the best overall outcome and survival. So as I mentioned, this is a table, or a graph rather, used for the chemo managements for colon cancers, which again are very similar to the management for appendiceal cancer. But again, we started with very few chemo options, and over the years, really growing the various regimens to such that we're able to really improve the overall survival with chemotherapy alone. And obviously we've improved from the surgical aspect as well, from the management of really, treating just the primary tumor to really expanding upon that and using surgery as a modality to treat either recurrent cancers, so folks who have had multiple HIPECs, and obviously metastatic disease. We have learned with better anesthesia management, better post-operative and ICU care, and obviously better tools and things that we use in the operating room to really, get you through the surgery with the least risk. With, again, the obvious goal of getting you back to a level of a healthy baseline living, or for some folks, getting you back to chemotherapy. So peritoneal carcinomatosis essentially is just seeding of some malignancy in the abdominal cavity, the majority of which is usually from a GI origin. And these are just some of the diagnoses that we treat, from those that are on the more aggressive side to those that are on the more less aggressive side. And then this is actually our data from UPMC over our last 20 years. As Chris mentioned, we are quite a powerhouse for HIPEC. So actually, I was working with our database coordinator, Lauren Hall, who's wonderful. And we've actually done close to 2,000 HIPEC since 2001,
Wow.
which is astronomical to me. But when you look at the top 4 diagnoses, it really focuses on appendiceal being one of the primary ones, colorectal being second, mesothelioma, and ovarian cancer. There are obviously, and those 4 really encompasses about 90% of the diagnoses of which we treat with CRS HIPEC. The remaining 10% are some of the more obscure diagnoses, some of the less common ones that we treat. However, again, being at UPMC, I think we have the ability to sort of push the envelope a little bit for some patients and give them that hope in a very nuanced manner. So again, with our experience, knowing which ones that may benefit and which ones may not. So again, obviously, patients who are untreated become quite symptomatic. They develop chronic abdominal pain. They have a significant amount of weight loss. They develop a lot of ascites, making it difficult to move around, to breathe, and ultimately pass from bowel obstructions that are unmanageable. And so with that, that's really how CRS HIPEC came about. Again, it is obviously a very aggressive treatment modality for this disease process. Essentially, the goal is to remove any tumor you see with the idea that the heated chemo would take care of the microscopic cells that I can't see. And it's funny how each surgeon describes it to their patients. I've heard it described as peeling an orange. One other surgeon described it as chipping paint off a wall. But most recently, actually, I had a nurse practitioner that used to work with me when I was at Cornell, and the way she described it to patients was, if you're cooking and you have a very dirty pot and you have the soap and water that gets rid of the majority of the gunk, but really Dr. Ongchin is going to be there to chip away at the stuff that is stuck to the walls, which I thought was a hysterical analogy for HIPEC. But again, I think it's something that conceptually patients have difficulty really, imagining what we are doing during that day. I think regardless of how you describe it, obviously, as you all are aware, it is a massive procedure. But again, the ultimate goal is to really relieve you of your symptoms, get you to your next steps in treatment, and improve your outcomes. Again, a lot of you folks, again, are very long-term survivors. But for some folks, there are obviously risks of recurrences. So we do like to think of this as almost resetting the clock, that in doing so that, despite the fact that you may recur, we are giving you quite a bit of time where you're not in and out of the hospital, you're not symptomatic, you're not on chemotherapy, so that you actually have some quality of life in that time frame. And obviously, with the length of the procedure, we do everything we can to really make sure that you are comfortable and safe throughout the entire process. We are very cautious about how you're positioned, how you're padded, make sure that we keep track of your temperature, make sure we're trying to minimize, again, the risk of blood clots. But again, at the end of the day, our goal is to leave that OR with no visible disease, no cancer, so that we can get you to your next steps. Once we do all that chemo, we remove all the, at the end of it all, we remove all the catheters, we put everything back together again. Some folks may end up with an ostomy, some folks may end up with a drain, but again, those are all on a patient-by-patient basis. And then, as you can imagine, the postoperative course is not going to be the same across the board for each and every patient. And so obviously, postoperative complications can occur, but I think early recognition is really what's important to minimize the treatment-related morbidity as well as the mortality, to maximize the survival and quality of life. And again, ideally, if your goal is to return to systemic chemo, it is to get you to that point as quickly as possible. So again, I'm describing this very long procedure. So how morbid is it actually for a patient, and what should a patient expect? So this is actually a paper that was put out quite a few years ago, actually, 2008, which really looked at the risk of complications and mortality from a few major series on across the country. And again, keeping in mind that these are some pretty older studies, so we may not have had all the experience or knowledge back then. So if you can imagine, the risk of complications and the risk of mortality was quite varied amongst institutions. I think since We've learned a lot more about the patients, about the biology of the tumors, and just advances in our surgical technique. The risk of complications and mortality are actually quite standard across the board if you're going to a high volume center. So being the risk of a major complication roughly about 30% and the risk of mortality in single digits. So again, though there is a lot up front to risk, I think the risk of mortality is quite low. And this is actually our Pittsburgh experience looking at the management of carcinomatosis in about 122 patients, where again, overall risk of complications, again, is about 50%. Most patients will, about 50-50 will develop some sort of complication, but a lot of those are quite manageable. The largest ones, the more common ones being wound complications, as well as an ileus, which is slowing down of your bowel. As you can imagine, these are, for the most part, managed with very minor techniques. Much more major complications is roughly, again, about 30%. And then the risk of mortality, again, is quite low. And then when you use our data and compare to the rest of the centers in the country, again, we sort of fall in line with everyone else. Again, really emphasizing the fact that, having experienced surgeon and having an institution that is experienced in taking care of such nuanced patients is extraordinarily important. And then this is just another paper looking at the NISQIC database, which is a nationally validated outcomes-based program. And again, very similarly across the board, we've come quite a long way that I think the outcomes across the country are quite similar. So one of the criticisms about HIPEC in general is the fact that, again, obviously there is a high risk of complications, and it is, for some folks, a crazy thing to go through. But again, I think if you compare it to the mortality from chemotherapy alone, it actually has very comparable mortality rates. So again, I think if there is a potential or a chance to render you disease free, I think it's definitely worthwhile. And when you look at the survival benefit, when you compare it to what we do for other stage 4 cancer, so this is just a paper looking at how we treat colon cancer with liver metastases. It seems pretty straightforward. We've been doing it for years, and patients have good outcomes if we're able to resect their liver disease in its entirety. Well, if you compare it to how we manage colon cancer or CRS HIPEC patients, if we're able to really remove all of your disease, your overall survival is the same compared to those who have liver surgery. So again, really supporting the fact that this is, despite it being aggressive, a very reasonable option for many folks like yourself. And again, looking at CRS HIPEC compared to what most folks would consider quote unquote high-risk surgical procedures, again, the outcomes compared to, say, a Whipple procedure for pancreas surgery or an esophagectomy for esophageal cancer, again, the outcomes over time are exactly the same. So again, I think this should be something that is definitely discussed in a patient with carcinomatosis, regardless of whatever stage you're at, because again, I think it is something that should definitely be part of the algorithm going forward. So is it for you? How do we decide which patients get surgery and which ones don't? So for us, from our standpoint, when a patient comes in with carcinomatosis, there are a few things that we consider from a medical standpoint. What other surgeries have you had done? What prior systemic options have you been on? Obviously, have you had a response radiologically? I know Dr. Baumgartner gave a great talk last month about how to read CT scans. So we look at your CT scans very closely and really try to compare your post-treatment scans to your pre-treatment scans to really see which ones would benefit the most from this procedure. And then obviously looking at blood work. All these cases are presented in a multidisciplinary tumor board because, as I mentioned, every patient is a little bit different. So it's something where we really do appreciate the opinions of the rest of our surgical oncology staff, our medical oncologists, our pathologists to really come up with a dedicated plan for you going forward. And I think what plays most into whether we decide surgery is for you or not is the patient themselves. We really look at their symptoms, their functional status, what are the medical problems do they have, and are they able to tolerate other procedures. So again, I think these are all important things that we consider for each and every patient that potentially may undergo CRS HIPEC. So, obviously, I spent quite some time talking about, it's a very lengthy procedure. There's a high risk of complications. There's a long recovery afterwards. Why in the world would anyone sign up for this? You guys must be crazy. So obviously, I'm not here to sell HIPEC to any of you. You guys know more about this than probably I do. You've experienced it yourself firsthand. You've made it to the other side. But I think what's important is that, again, you guys are the reason we do this. So this is actually one of my very first HIPECs, actually, when I finished fellowship. He was wonderful, Jose. He was just recently married and was from Puerto Rico, where they had very limited treatment options for him. So basically they told him, you have, he actually had mesothelioma, but basically was told that they had no options, go to hospice, go have a drink on the beach, call it a day, this is it. We have nothing to offer you. So as you can see from his scan, again, just briefly describing CT scans, this is you laying on a CT scan table, and here's your back and here's your belly. And this is his left chest, and you could see it's completely full of fluid. And as you scroll down, it extended all the way into his belly. As you can imagine, he was quite symptomatic. He was losing a significant amount of weight. He was very depressed. This was his chest x-ray before he came to me. And again, you can see his entire left chest is full of fluid, to the point where it actually shifted his heart and his trachea. So to this day, I am actually amazed he was able to tolerate a flight, let alone a 4-hour flight to Manhattan to make it to his appointment without any major cardiac complications. But again, if anything, I feel that really speaks to the patient's resilience and grit and his determination to get to surgery. So from that point on, we saw him, we scheduled him for surgery in about 6 weeks, but really those 6 weeks were dedicated time to get him ready. Unfortunately, he made it through surgery without any complications, and he was able to return to Puerto Rico about 2 months later. And this is him now. This was about 3 years ago at this point, but he is 7 years out, still sitting on a beach drinking, having a drink, but in a completely different place than where that conversation started. So I use him as an example because, again, I think something that I was doing subconsciously without physically putting a pen to paper was this concept of prehabilitation. So again, I know Dr. Virapong, I think in one of the very first HOPE Zoom meetings in last spring, talked about prehabilitation, but I really wanted to spend a little bit more time talking about, what that actually entails and how to get you guys prepared or better prepared for surgery. So then again, as I mentioned, I think as surgeons who do these procedures, we all talk about the elements of it. We tell you guys stop smoking, eat better, be active, but we don't really give you anything or any guidance as to how to do so. And I think that's where this concept of prehabilitation comes from. And it's really not actually a new concept. It's something that actually developed in the 1940s with military recruits in Britain. And it was something where recruits who were not prepared or not ready for active duty were basically rejected from service. And they were losing quite a few recruits in doing so. So this concept of prehabilitation came about, where basically these recruits were enrolled in a prehab program where they were given, three square meals a day. They were given physical exercise, they were given education. And what they found was after about 2 months, over 85% of these folks passed their physical and qualifying testing exams, so they were able to participate in active duty. So again, obviously, this is definitely not a new concept, but I think the application in the medical field is slowly growing over time. So again, the concept really is to enhance the general health and well-being of a patient before any major surgery or treatment, really utilizing a multidisciplinary interventions with the goal of improving and sustaining these patients after sustaining them after any major surgical procedure. And what we found is that it has been quite effective. So again, what does this look conceptually? So again, imagine this graph being a timeline of your disease course from when you're diagnosed to living and dealing with your cancer later on. And then this dotted line being your functional baseline. So again, without any sort of prehabilitation, the stressor in this case would be CRS HIPEC. So at this point, there's obviously, after any major operation, a functional decline as to be expected. And then with support like physical therapy, nutrition in the postoperative period, patients can slowly return to baseline, however, in a somewhat slower process than one would expect. Now, the concept of prehabilitation comes in where if we are able to elevate your level of baseline before that insult, this really allows for a larger buffer afterwards so that you're able to continue to utilize the same concepts and behavioral patterns that you did in the prehab period, in the rehabilitation period, so that we're able to get you back to baseline much quicker. So again, prehab has really been applied to a lot of non-surgical treatments, a lot of elective procedures such as orthopedics. They've really done probably the majority of the research in prehabilitation. However, the application to cancer surgery really has been slow to progress. But I think over the last few years, definitely something that is emerging and becoming more relevant. So I think in thinking about prehab for cancer patients, I really do actually like this definition from a paper put out a few years ago, which really encompasses the fact that prehab for cancer really is multimodal. It requires physical aspects as well as psychological aspects with the goal of improving your present state so that you're able to bulk up and be able to be prepared for the future insults coming at you. So again, I think one of the biggest aspects of this, is to focus on is the fact it's a personalized program. Not every patient is going to be undergoing the exact same program. But I think the three modalities for the three sort of pillars of it would be exercise and physical therapy, nutrition, as well as psychological support and behavioral health. So I think when you come with a diagnosis of appendiceal cancer and you're deemed a surgical candidate by your treating physicians, ultimately it should be a huge team of folks to get you to the finish line. So what about prehab for CRS HIPEC patients? So it's interesting in that this actually isn't a novel concept for CRS HIPEC. It actually was something discussed at the SOGI conference in 2018, which again acknowledges that this is a major surgical procedure and that a prehab program would be very important to quote unquote enhance your physiologic reserve in anticipation for the stress of this surgery. However, since that point, there really hasn't been any good clinical trials or current standards in place to really define what this entails. And I think part of that is you guys are a very unique patient population and you come with a lot of barriers to something like this. This is actually data that I kindly borrowed from one of our research residents, Carolyn Reiser, who's wonderful, and her focus for research has been looking at surgical frailty in CRS HIPEC patients, and her and I have been developing this prehab program. So I borrowed this slide from her where she looked at our database of our CRS HIPEC patients and found that, again, about 60% of you all are coming to surgery after receiving chemotherapy, which already is a stressor in and of itself. 40% would be deemed frail, a quarter are malnourished, a quarter are depressed preoperatively, which only worsens in the postoperative period. And then about 3/4 of our patients come from quite some distance. So again, as you can imagine, you don't have your medical support team readily available in your same town. So I think these will all be considered barriers to trying to develop a prehab program for you. But I think despite this, I feel like, again, CRS HIPEC patients may come in a little bit more beat up perhaps than a typical, say, orthopedic surgery patient. But if anything, I feel like this really supports the fact that you would gain the most from something like this. There is no competing ERAS protocol or enhanced recovery path, because again, as I mentioned, everyone's postoperative recovery is a little bit different. Again, I think you guys as a patient support group have described this procedure as the mother of all surgeries. I've had patients describe it as trying to prepare for the Super Bowl. So again, as a surgeon, how can I expect good outcomes without providing you the resources and tools to be successful? And again, lastly, I really do think that you guys come from a slightly different perspective on quality of life and outcomes. Again, as I mentioned, many folks are very symptomatic. They come after months, if not years of chemotherapy. So I think having any incremental benefit gained from a program like this is huge for a group of patients like yourself. So again, essentially, what my interest in, since I've actually come back to Pittsburgh, had been really developing a prehab program for our CRS HIPEC patients and working with Carolyn to really do this in a clinical trial setting, utilizing, like I mentioned, the three main components of nutrition, exercise, and behavioral health. So sort of conceptually, it's in my mind, this is sort of how it would play out. Again, as I mentioned, every patient's prehab program would be individualized. So I think we have to know where you all are starting out from. I can't expect a 40-year-old fireman to gain the same benefits if I ask them to walk 3 times a week, as opposed to, say, a 70-year-old patient who's been on chemotherapy and sedentary for most of their day. So I think I really need to we need to focus on screening every patient coming through the door to really get a sense of what their baseline is. There's a whole bunch of validated surveys with a bunch of acronyms, which I'm not going to bore you with, but really getting a sense of where everyone is starting out from, so we know what we need to do in that time frame to then develop an individualized program. In addition to that, really utilizing our APPs and our office support staff to do weekly check-ins to make sure, number one, that you are adhering to this program, to ward off any unexpected changes that may occur. But in addition to that, here at UPMC, we started working with some of our health coaches and utilizing these sort of motivational interview skills to really get you guys ready along your prehab path. Because ultimately, all of our goals at the end of the day is to get you through surgery successfully with the goals of improving your symptoms and returning back to treatment as quickly as possible. And I think one portion of this that sometimes is not really focused on, and I think it's fantastic that you have someone like Connie, who is such a great caregiver support system, it is the fact of, and the role of caregiving in a process like this. It is psychologically and physically very demanding for the caregiver. They not only have to help the patient out with their ADLs, but they still need to do the day-to-day activities like grocery shopping and making meals and laundry. So again, this is a huge toll on the caregiver themselves that I think sometimes is forgotten when we talk to patients. And this is actually a recent paper done at Wake Forest, which I think was one of the first papers that really highlighted how CRS HIPEC really impacts the caregiver. A lot of the concerns that they brought up, there were a lot of financial concerns. The caregivers found that they had a lower sense of social support because a lot of the focus was on the patient. They had a lower quality of life. And ultimately, what their study found was that there was a higher risk of depressive symptoms, which interestingly occurred at the highest level right before the surgical procedure itself for that patient. So again, utilizing this prehabilitation, not only to incorporate the patient, but also the caregiver and their support system, because again, at the end of the day, it really is a group project. It is something that, again, we really do need to do everything we can to really maximize the outcomes at the end of it all. So with that, I will stop and see if you guys have any questions. You probably would have more, you guys have probably more experience and more input on this than myself.
Well, first of all, I mean, that is a fantastic presentation. And, we chatted before the show started, and I said, us getting to meet you and know you on a more personal basis and understand the the whole comprehensive approach that UPMC and you take to care. I mean, that was truly amazing. And I think you're hitting it on the head. The caregiver experience is also very difficult and in many ways equal to the patient experience. So it's a very tough road. I love the discussion of prehabilitation. This is a huge procedure, and so preparing for that is really necessary. Emotionally, physically, with your diet, it's great. So absolutely.
Well, and I also think as patients, we can't do our own surgery, but some of the prehabilitation things that you've mentioned give us control. We feel like we're participating in our best outcome.
And I love the caregiver study done at Wake Forest. And it's what a great study. And it's no surprise to me, and I'm sure to most of us here, that those depressive symptoms maximize right before surgery. Because to Adele's point, that's right. This is control is taken from us over our most fundamental bodies, right? And knowing the outcomes from these procedures. And so it's a very scary time. That said, there, a couple of points that came to mind for me. We saw some of the survival data, and I wanted to, point out that those are old studies too. I mean, I think there's great survival at that point in time, and it's always scary to see those numbers, but I am certain that the numbers are better. We have the benefit of attending the annual symposia with our wonderful surgical oncologists, and we see the numbers, and they're much better. And I know, I've been doing this for 16 years, and every one of you that is seeking treatment or navigating treatment, we always do better than we think.
Yeah.
There is always, unfortunately, some physician who has the unfortunate responsibility of giving the worst prognosis, right? A number that's going to be scary to us about time, and that, we should prepare for that. But I'm telling you, we do much better than that. We really do. And there's great life to be had. But it does. You have to focus on the physical, the emotional, and these other things too, to try and find that peace in the midst of it all.
Yeah.
So
Absolutely.
we have questions that patients have asked. They email them to us. They send them as they register. Adele, can we start to go through some of those questions?
Yeah. So one of the questions was about a patient having multiple HIPECs. Can you speak a little bit about that, and how many can a patient have, and when are they eligible for a second HIPEC?
Absolutely. So we definitely do obviously multiple HIPECs. Again, sometimes I feel like it's crazy. I mean, for you to sign up for one, let alone more than one. But I think it really depends on the tumor biology. So again, it's usually more so for some lower grade malignancies. So like an appendiceal cancer or PMP, where again, a lot of it is sort of this gelatinous-y, mucinous stuff that patients it's a very slow growing process. So, sometimes after your first HIPEC, if you do recur, there's always that potential to do so. But things we consider is, number one, the time frame from which you did recur. Obviously, if it's a shorter time frame, again, you may not get, quote unquote, as much bang for your buck, each and every time. But again, for these lower grade cancers, like, a lamin or something like that, we can get you a lot of time where we just sort of have to, again, almost like a tune-up, kind of do another HIPEC to really clean things out one more time. I think the difficulty sometimes with that, as far as the number of times really, is things we consider are, at your last surgery, how difficult was it to get back into your belly? And I think that's to be said, every time we do a HIPEC, there's a lot of scarring, there's a lot of inflammatory response, that if you can imagine trying to get back into your belly a second time to take out one little tiny nodule may almost cause you more injury to the bowel, just getting to that one spot because of all the scar tissue. So I don't think we have a good, time, like number of times per se. It's not like you can be maxed out. It really more so depends on the patient's tumor biology, sort of their disease pace, and again, just sort of how much scar tissue their belly has.
Thank you. Another patient asked if you've worked with patients that have mucinous adenocarcinoma involving the lymph nodes, and what's the usual prognosis? How does it spread? Is it controllable?
So I think lymph node disease, regardless of etiology, sometimes is difficult. You know, how I describe it to my patients, you know, your lymphatic system, it's you have lymph nodes head to toe. I describe them as grapes on a vine. So your lymphatic system is very similar to your circulatory system. So patients who have mucinous adenocarcinoma to a lymph node, yes, we can go and take that lymph node out. However, there's always a potential you may have microscopic cells floating through that vine. So it's something where, from a surgical standpoint, it's difficult to, we can't take out all of your lymph nodes head to toe. So it's something where we combine it with something systemic to really treat the microscopic cell that might be within your lymphatic system.
I see. You know, we do have some patients on the call that are waiting for their surgery. What about some other conditions? So some of them might have other conditions on other health concerns, whether it be, you know, diabetes, heart issues, lupus. Can you give any advice to those patients on what they can do from a prehabilitation standpoint?
Absolutely. You know, I think, you know, modifiable factors, you know, just starting with the easy stuff, you know, smoking obviously decreases oxygenation decreases wound healing. So trying to cut back on that as much as possible. Making sure your diabetes is well controlled, because again, poor sugar control also increases your risk of poor healing afterwards, and increases your risk of complications. So trying to get all your medical conditions as optimized as possible beforehand. So really working closely with your primary care doctor, your cardiologist, things like that, to really make sure that those factors are ready for really the stress of surgery. You know, depending on your cardiac comorbidities, you know, if you've had a history of say a heart attack and you're on blood thinners, or you have stents and you're on antiplatelet medication, I always send those patients to cardiology just to make sure that their heart is healthy enough to undergo a 12, 16-hour procedure. There's one patient I'm thinking of in particular where she actually had a lamin, so a low-grade tumor, low-grade process, not symptomatic from it, but just had a very, very bad heart. So it was one of those, she really wanted it treated, she really wanted surgery, but from my standpoint, it doesn't make a lot of sense for me to get to finish surgery and then you to have a massive heart attack afterwards. What benefit is gained there? So I think, you know, from our standpoint, we really do work with your supporting physicians to maximize the medical standpoint. Other things, obviously, like we mentioned, you know, from the prehab standpoint, is nutrition, increasing your protein intake. For us, we always check labs before taking you to surgery. So we look at certain vitamin levels, we look at certain protein levels, so we know sort of where you're starting from and how we can improve that before we get to surgery. And then obviously physical activity. As I mentioned, I think these are things we all talk about as physicians, but you know, at the moment we don't have, you know, go walk 3 times a week or use this resistance belt, you know, 20 minutes a day. But I think, you know, going forward, that is my goal, that we can have something in writing for you to do. You know, feel like nowadays we have an app for everything. So ideally, if we can get something where something does like a push notification, like, hey, you got to take a few steps right now, things like that, to really almost remind you to get ready for something coming up.
Absolutely. So when patients are on the other side, would you have recommendations post-surgery, post-habilitation? And would those be similar to your prehab recommendations?
No, absolutely. And I think part of prehab, you know, even though it's not really, you know, concrete in nature per se, is just really building healthy habits. So I think if you're used to, you know, eating more protein, you know, in the post-op recovery period, you're sort of used to sort of those types of meals. And then after surgery, keeping those habits really will help improve your recovery. Again, I think a lot of folks, especially, you know, anyone with adenocarcinoma, you know, there's always potential for needing more chemotherapy. So I think, again, it's one of those, you know, maintaining those skills so that we can get you through chemo, because chemo definitely will wipe you out. And patients feel quite crummy going through it the first time, let alone after a HIPEC. So I think, giving you all the buffer we can so that we can get you through through chemo is definitely important. So again, I think prehab as a concept, we may, give you a prescription for these are the things you need to do, but really utilizing that in the post-op period to really, emphasize, the habits really going forward so that we can get you to the next step, like chemotherapy.
We have a patient that's recently diagnosed with Lamin, healthy, but is in the process of trying to find a surgeon in a facility. What advice would you have in narrowing down the selection?
Well, number one, I think being on this call alone, I think number one, you have a huge nationwide support group that can probably help navigate, where the surgeons are. I think your support group, your website helps enable patients to figure out where. Obviously, I'm more than happy to help find you a doctor as well, depending on where you're located. I think, again, despite the fact that I think there's a growing number of HIPEC surgeons, I think the more folks we train and they go out and do HIPEC in their own institutions, there's definitely a growing number of HIPEC surgeons as compared to, say 10, 15 years ago. So there's definitely, more surgeons out there. And I think it's one of those, just knowing and being accessible is important. But yeah, I think, as far as how to find a surgeon, I think this is the perfect forum to do so.
Well, Adele, I'll take a moment because I will just show the group how to navigate our website and how you can find some of the information. It might be worthwhile to pause there for just a second. This is the PNP Pals homepage. And as we're discussing, there's a couple different bits of information here. If you are searching for a surgeon, under the treatment menu, right there is our Find a Surgeon map. And you can see not just in the US what surgeons are available, but you can absolutely see globally where you can seek care and find physicians. So we're always updating that information. So stay tuned for more. Likewise, if we go back to the homepage and you're looking for support and information, all of our Hope Zoom videos are located here, our physician calls from the past. You'll find fascinating information on HIPEC, some clinical trials with Bromac to help dissolve the mucus that comes from our disease, pathology, as mentioned by Dr. Ongchin, how to read a CT scan, because that can be really confusing, but lots of great information here, and I'd encourage you to go there to find it. Thanks for the short commercial break.
It's like we planned this.
Right? We've done this once or twice before, so yeah. Good.
Exactly. You talked about screening patients for the prehab. Any thought to screening caregivers?
No, absolutely. So actually, it's again, this is definitely a project, a baby of mine. Since I've come back to Pittsburgh in the last year and a half. But it's fortunate that I actually paired up with one of, like I said, the research resident Carolyn, who's wonderful, who's interestingly had an interest in fertility, frailty in CRS HIPEC patients. So our sort of research interest sort of worked well together. So actually our first step is actually to interview sort of 3 different groups, one of which is actually caregivers, to really see what are their needs, so that when we actually put together, again, pen to paper, what our prehab program is, that we don't forget that aspect of it. So again, our focus was looking where our aim 1 actually was interviewing, number 1, surgeons who do the procedure, patients who have recently undergone the procedure. What would you have liked out of a prehab program if it was offered to you? And then lastly, we're caregivers, because again, I think that is a huge component to the recovery.
Thank you. Could you share with us the typical physical therapy pre-op protocol?
So I think it's funny. I mean, we tell patients to do physical activity. So I think what we're envisioning is actually when you come and see us as a surgeon, we deem you a surgical candidate. We're going to get you scheduled for surgery. Again, for the most part, there's always, at least 4 to 6 weeks before, our office visit and when we do surgery. Rarely is it a situation where we see you and then we do surgery the next day. So we always have some time to really work with. But also having you see our physical therapists in the office. They will do all of the assessments and then essentially work one-on-one with you, basically almost like your own personal trainer to dictate, what you need to do. Is it more cardio? Is it more strength training? So our pre-op, program would really encompass a little bit of both. I think as far as the screening process, again, like I mentioned, there's a whole slew of different screening processes, but basically we really focus on, there's a 6-minute walk test, there's a balance test, there's, a 30-second, chair stand. So there's certain things that we can gauge so that, from a research standpoint, there's actual tangible, measurements for me to use, from when you had your diagnosis to after the program to then after your surgery. But really utilizing a combination, it's really a combination of both cardio as well as strength training. That really, so whatever that entails for that patient. So some folks, we recommend, walking. They recommend usually it's 150 minutes, broken up around 3 times a week. Obviously, very easy for some, maybe a little bit daunting for others. So again, it's one of those, that's why we sort of really look at the screening process to see, well, maybe you need to do a little bit more. Maybe, you have, when they, when we check your labs, you have an element of muscle wasting because you've been on chemo for a year. Well, that is something where, we send patients home with these pedometers. We send patients home with these resistant bands. We're trying to get funding to get those pedals things, the under the desk pedal things. So that just mindless, you are watching TV, you can keep yourself moving. So I think these are things that, again, we can tell patients to do so. But I think in a program like this, if we physically give you those, as well as give you a physical therapist who will call and check in on you, I think really the adherence to the program is much stronger.
Wow, thank you.
Adele, I see a question that I'd like to ask, actually.
All right.
And so, and I apologize, right? This will be the question you were just about to ask. But hopefully it's not. But I see a question up from before. It says, does CRS HIPEC always involve removal of bowel necessarily? Or do you have cases where it's just a small amount of disease and we don't have to resect any bowel?
Yes, there are times where we may not have to remove any bowel. Again, a lot of those are usually more so like in a Lammin case, because again, those are really non-invasive types of diagnoses. And again, a lot of those are just kind of scooping things out, peeling the peritoneum, as I mentioned, chipping the gunk off of your pot. So, really doing these peritonectomies, but not necessarily doing a formal bowel resection. So not every CRS HIPEC necessitates a bowel resection. If anything, we try to minimize that if at all possible. We have a lot of patients that come in who, say had their primary colon cancer already removed elsewhere, and basically they have peritoneal disease. So basically we just go in and take those spots out without really necessarily taking bowel at all. So again, our goal is to really minimize any visceral resection if possible. So absolutely, there are definitely ones that we don't have to do any bowel resect. Those are like the easy days. Those are the ones that are straightforward. I'm like, this is going to go well. These are our baby HIPECs. These are our baby HIPECs. So these are ones that, again, they're almost enjoyable because it's almost like it just flows very well. It's just very straightforward.
That's great. That's great. And your excitement just shows, right? I mean, on the other side, right, there's often mystery about what goes on in the OR and with the medical teams, and just seeing your excitement that I know that I can help this patient. This is going to be a HIPEC. This is going to be a good surgical outcome. Let's manage this patient and get them back out in the world to live a productive life.
That's exactly it. There's certain folks, they'll get referred to me with, low volume disease. There's like 3 or 4 spots. They have a low grade tumor, and they don't want surgery. Again, not to say that I sit and push them for surgery, but like this is like the small percentage. Like you are the one that would do so well with this. But it's groups like this that, hearing it from the other side of things, to really get them to that point. Like I said, I had one patient, she had a mucinous adeno from the appendix. She was completely young and healthy. I mean, when I say she literally had like 3, she had like almost like nothing. But she was very, very hesitant and she would not undergo it. And, unfortunately, her only other option was chemotherapy, where I said, if there's anyone that would do well, you would be the one that would do well. So I think it's certain folks like those that, make it worthwhile doing, what we do. And obviously, getting us, our experience has shown that, we can do those, but we can also do the bigger cases to, again, really have a better sense of, how aggressive we are in the operating room.
We likewise on our end supporting patients and caregivers, we have these weekly Zoom calls. Folks, we have this call every week, 11 a.m. Eastern time. And the support calls will go for 3 hours as we just give people a chance to talk and go through these. But we see patients too that would benefit so much. And we do our best to carefully try and encourage them in certain directions, but it's tricky. It's really difficult. And, at the end of the day, we know that whatever and now I'm talking to the audience, whatever care is right for you and you decide, and that's across the entire spectrum. Some patients decide they don't want to go through treatment, and that is okay. We'll be here to support you through that too. But yet we understand, we see cases, and we've been lucky to, with the help of physicians like you, navigate people to treatments that are really going to benefit them with minimal side effects for sure. So, yeah.
Absolutely.
Yeah. And another question that came up, this is a patient that is vegan with, a BMI of 23. Would you suggest an animal-based diet prior to surgery?
So I don't push any diet per se. So actually, it's funny. I recently just saw a patient who she had undergone 2 HIPECs. She said the first time she was not vegan, the second time she was. And she actually said she had a harder, and she's 42. She said she had a harder time recovering from the second one because it just took a little bit longer to figure out where she can get protein from a vegan diet. So there are definitely vegan protein options. To be honest, I don't know what she used, but it was something where, we have you working with our nutritionists to really, again, there's plant-based proteins and things like that can help provide that aspect of your nutrition without having to change your preferences.
But protein is the key takeaway from what.
Yes. Lots of protein. I tell patients, again, I train under, the folks here at Pittsburgh, but any calorie is a good calorie. Again, I'd rather have you eating a whole cake than eat nothing that day. So anything you want to eat, protein preferably, but I'd rather have you eat something than nothing.
That was for Jamie.
Yep.
That was a great call out. That's right. Because Jamie was having cake last week.
Oh.
Yep.
That's true.
What are your thoughts on homeopathic therapy?
So I support anything homeopathic, as long as you're doing it concurrently with traditional medicine. I think where it makes it difficult for a physician to recommend homeopathic treatments is where patients go that route only. Because again, there's not a lot of research into supplements, or there's not a lot of research into, I've had patients fly to Europe for these, sauna treatments and things like that. So I think, because of the lack of research, it makes it difficult for a physician to recommend those. But I think if you use it concurrently, I think that's fine, as long as you talk to your treating physicians to make sure it's not going to interact. But yeah, we do get asked a lot, what if I take all these supplements? What if I take all these vitamins? I want to go to Arizona. I read about these vitamin infusions. I think again, as I think Chris had mentioned, I think a huge part of this is, just control. So again, who am I to sit and control what you want to do? But again, I think it's something where if you do it with, number one, with your physician's knowledge, but also with what they're recommending, I think that's reasonable. But doing it in replacement of, I think that's where it becomes difficult for a physician to recommend.
Thank you. Are there any determining factors for recurrence?
So yeah, so after any HIPEC, we follow you closely with blood work and tumor markers and scans every 3 months. Obviously, how I describe it to patients, as the one slide showed, every cancer, there's a spectrum of aggressiveness. So obviously the chances of things recurring when you have, maybe an appendiceal cancer with some more aggressive features are going to be a little bit higher than a lamin alone. So I think, are there predicting factors? Possibly. So like, for example, if you had a very high tumor marker beforehand and maybe say after surgery, your tumor markers did not drop to what we would expect. It feels like there may be something brewing or something along those lines. Or if, say you had a very aggressive tumor where you may not have gotten a true CC0 resection. Maybe there's microscopic disease on a major blood vessel where it was just not feasible to resect. Well, that's something where, we make sure we look at that area every time you get that scan, because that is always a potential spot for things to recur. So I think there are certain things we look at, both from both radiologically and a blood work aspect, but also, what we do in the operating room. Did you get everything out? Did you not get everything out? And if not, where was that? So that we can keep an eye on that.
I am looking through our questions.
And I'll let people know, if you have questions about your case, you can email them to zoom@pmppals.net. You can also share them in the chat if you can find that functionality down at the bottom of your screen. You can ask questions that way. If you want to raise your hand as well, we may select certain patients to ask their questions. But as we're getting some more questions in, I'll also take a moment and show folks how they can stay connected with us throughout the week, because we do support you throughout the week. We're not just here on the weekends. We have a number of ways to connect with you and support you. As I pull that presentation up, we'd encourage you to stay connected with us through our various programs, because there's a lot that we do. Not only do we have these weekly Zoom calls, but we have the Bare Bottom Bears program, and you can and should request a bear as you go for your HIPEC. We send that to you. This is one of our oldest programs. I've got my bear with me right now, and they'll go through treatment alongside with you. Adele is actually behind the info@pmppals.net email. She's there answering questions. And this is our founder, Gabriella Graham, in this corner of the picture right here too, just so you're aware of that bit of history. If you have more technical questions, Arthur Redig's a retired pediatric surgeon and PMP patient. He loves to answer your technical questions, so feel free to reach out to him. Our most popular program is our Get Well Cards program. You will receive a box of cards from patients and caregivers around the world, reminding you you're not alone, even though you're fighting rare cancer. And we're happy to send you a starter kit with helpful information on the disease and the organization, chapstick, which is going to be helpful if you're going through chemotherapy, and some hand sanitizer, which you're going to want to be using, especially in our COVID days. Some cards that'll help you get to the front of a bathroom line, and some wet wipes that you'll find you'll need throughout your treatment and recovery. We will remind you that we are a completely donations-run organization, and so we would ask for your donations. You can go to our website and donate there, and you can also register PMP Pals as the organization you support through Amazon purchases. If you go to smile.amazon.com, you can register PMP Pals, and we'll get 0.5% of all your purchases. And all those little donations do add up quickly. And again, I'll remind you, you can find us on the web at pmppals.net. On Facebook, we always have social media there. And on Instagram, you'll have inspirational quotes at PMP_pal throughout the week.
And Chris, one more thing that Charmaine actually just reminded us, this marks 1 year of us doing these Hope Zoom calls every single week.
It sure does. It sure does. What an amazing year it's been to be able to connect with everybody. I've been doing this for 16 years. Gabriella Graham, our founder, used to have an annual conference when patients could get together. And it's really hard to explain the magic that happened at those events. And it's been like a conference every week, just being with everyone together. So it's been a big year. Grateful for it.
Okay, well, we've had a couple of other questions come in. One additional question, how much in advance before the surgery would you suggest a patient start increasing their protein intake?
And anywhere from 4 to 6 weeks. So, again, usually when you're at your preoperative visit, you can, check your blood work. They look at your protein levels. Ideally what they recommend is, 1.5 grams per kilogram per day is the recommendation. Again, anywhere from 4 to 6 weeks is ideal. A lot of places, ourselves included, will give you, cases of those, nutritional shakes, Ensure Boost. There's clear ones if you don't like the weird milky consistency. Other folks, like I said, what I've mentioned to them was, if you want to buy, protein powder, make yourself a milkshake, ice cream, milk, whatever it may be, throw a scoop of protein powder, and that's, a huge source of calories as well as protein for you. So again, I think once you're getting surgery, especially a surgery of this magnitude, I think that's the time to start. There's no early time per se. You can't start too early, but you can always start too late.
Can you talk a little bit about watch and wait for a patient with some limited disease?
Mm-hmm. Absolutely. So usually watch and wait is more so for folks probably with, like a low grade lamin or something like that, where yes, you have HIPEC and say it's 6 months and say there's a little tiny blob of something that we're keeping an eye on. And then over time, we're watching your scans and that little gray spot has gotten a little bit larger. I think for things like a PMP or like a lamin, again, knowing the biology, that it is a low grade process, meaning it's not going to skyrocket out of the blue, in a month's time. It's something where, at least for my practice is, if you've already gone through one HIPEC, if I can watch things for at least 2 years, I've at least given you 2 years where you're not symptomatic, you're doing whatever it may be before you undergo another surgery. I think folks like that, sometimes it's reasonable to go and do another surgery, but doing it 1 year, then 1 year later, where you've taken 6 months of that time just to recover, again, like I mentioned, you're not really getting as much bang for your buck as we'd like. So if we can push you to 2 years where you're able to live a normal life, I think that is ideal, where then we can, do it all over again and hopefully extend that time frame beyond 2 years.
And Dr. Ongchin, so talk about the scenario, and we're finding more of these, right? I think you would say that, over the years, more physicians are recognizing PMP earlier and getting them the care earlier, right? We've got improved imaging. And so we're finding these cases earlier. What about the case where you have a ruptured appendix that does turn out to be, to have some malignancy to it, right? Mm-hmm. And even if there's been that small rupture, what is the role of watch and wait there? And what's the risk of eventual, turning into PMP?
Absolutely. So I think, it depends on obviously the type of appendiceal tumor. So if it was, say, a lamin that was ruptured, again, usually those are acellular cells. So there's not, any cancer cells per se. So if you smear it on a slide, it's mostly mucin and really no cancer cells, no abnormal cells. This is a little different than, an appendiceal adenocarcinoma, where that's a true, almost like a colon cancer, like a true invasive cancer. Where again, the risk of things coming back are a little bit higher. I think, as far as, watch and wait in those situations, I think sometimes, if they've already hypothetically already taken the appendix out, you get a scan, there's nothing there. I think from a surgeon standpoint, there's some places that sometimes we'll do like a prophylactic HIPEC, just, do chemo with the thought that, you had a ruptured appendix. But again, I think the role of watch and wait is also very reasonable, because again, if there's nothing for me to physically see and go in and take out, what am I taking out? So maybe it'd be better where if, because again, just because it ruptured on that right side, as we know, especially with appendiceal cancers, those cells can travel basically all the way up that right side of your belly, up along your diaphragm. So me just putting chemo in may not necessarily treat everything that potentially may occur down the line. So I think it's sometimes in a situation like that, there's no right or wrong answer. I think it depends on, which physician and what their practice is. Sometimes they do these prophylactic HIPECs, and other times, we'd rather wait to see where it occurs and then offer HIPEC at that point.
Abdul, does that answer your question? Does that give you some things to consider? I think it does, but and for me to the patients, this is what makes it challenging too, as we are navigating our options and decision making, right? In this type of case, there is no definitive answer. Yeah. And so, there were questions earlier about how do we choose our medical team, and this is a decision about what care do we seek. And this is a decision that we suggest that people get a therapist right away and see them every week, because it's a process of talking through the options and starting to understand the pros and cons of each, and then deciding what's right for you. And it is very stressful. We know that. So it requires support. We have our support calls where you can do that. You can work through those questions, answers, pros and cons, and start to consider what's right for you. But there's not always a definitive answer sometimes, but we'll help you navigate that. It's tricky. It's really tricky.
No, I agree, Chris. I think, like you mentioned, not every patient situation is exactly the same, but I think what's sometimes difficult for us as surgeons are folks like yourself who were never told. We get this all the time. I didn't even know this was an option. So I think, groups like this, which really, is, providing the information to patients themselves, because sometimes, again, if you're in a smaller town in the middle of nowhere, your medical oncologist may not even know that this is an option. So it's something where you do have to do a little bit of digging on your own to be your own advocate to get to that point. It may or may not be an option for you, but again, it's something that you sort of have to talk through with your care team to see if it's something for you.
Yeah. Now, and pursuant to the same discussion, the next question is, can a CT scan catch everything? And we know, even from Joel Baumgartner's presentation, which you'll find on the Hope Zoom page, yeah, I think it's like 1 centimeter we can see, maybe down to 0.7 sometimes, but for the most part, we can't always see all the disease. And now, I'll ask this question, Dr. Ongchin, right? I've heard physicians say there's almost always more disease than we see on the scan.
Yep, 100%. And so what I tell patients, CT scans 100% underestimate the amount of disease. We can only see, things that are at least 1 centimeter in size, where again, a lot of these nodules are, 1 to 2 millimeters. So again, it's under the detection of a CT scan. And sometimes the next question that follows is, well, what if I get a PET scan? Is a PET scan any better? And the answer is actually no, because again, things that are that small are not going to be active. So again, unfortunately, we don't have a good radiology scan to say this is your amount of disease. Sometimes I've had patients that seem quite fixated on the number of nodules. They want to know how many.
Totally. Yeah. Oh, absolutely. Yeah. We're terrified. Every number we're like, because it's like, what's the difference? And right, having done this 16 years, I'm like, God bless you. We hang on every single number, and we don't necessarily need to, but
and for me, that's a very difficult question. 100, 10,000, it's hard for me to predict. And I sort of finish that with, again, these scans, they're not going to pick up nodules that are millimeters and so in size. So whether you have 10 nodules or 100 nodules, my goal at the end of the day is to leave you with no cancer.
Yeah, it's great. It's great.
Joanna, would you like to ask a question?
Yes, please. Thank you, doctor. That was a really wonderful presentation. It especially speaks to me because I'm in a period of kind of pre-HIPEC. I should be having HIPEC sometime this summer. My question to you is, I just was vaccinated, and now the CDC is, there's all sorts of new guidelines coming out, but I want to make sure that my immune system stays healthy and I don't go into surgery. Hopefully I wouldn't get COVID pre-surgery, but what are you recommending to patients kind of as we're in this kind of period where there's a lot of still gray area in regards to COVID.
Absolutely. If I can ask, are you undergoing chemotherapy at the moment too?
I am not, no.
Okay, so you're just waiting for surgery.
Yes. I just underwent a pretty major surgery where they found my appendix cancer. So now I'm in the healing process.
Gotcha. Okay. So I think number one, the COVID vaccine is wonderful. I think obviously, for folks like yourself, with a compromised immune system, I think anything you can do to protect yourself from any additional insult is huge. I think we know, obviously we don't have all the answers about COVID, but I think there's growing data that says for any major operation, if you have COVID, your risk of mortality through, not surviving is extraordinarily high. So if we can wait at least 7 weeks is sort of the sort of new guidelines at the moment. If we can wait 7 weeks from your infection, from your last symptoms, your outcomes are much better. So that's sort of what we recommend. I think someone like yourself, I think the one thing to keep in mind is even though you are vaccinated, you can technically still get COVID. So I would still use all the precautions between now and your surgical date. Wear your mask, 6 feet, try to be outdoors. Obviously, you don't have to seclude yourself in the house, but just be a little bit more cautious about mask wearing, because I think the last thing would be if you got COVID right before surgery. Obviously, your risk of complications from the surgery itself is already high, but I think with COVID, we know is quite difficult. I actually, there's a patient that actually got COVID who had HIPEC, got COVID from her daughter, and she's struggling more with the COVID than she is from her HIPEC. And so that's something that I think COVID unfortunately has thrown a little bit of a wrench for folks like yourself who already is trying to mentally prepare themselves for a huge undertaking. But I think the vaccine definitely is going to help tremendously for you. But I think, again, keeping precautions, especially right before surgery, would be important.
Thank you so much.
And best of luck.
Thank you.
Thanks, Joanna.
Thank you.
Good to see you.
Abdul, did you want to raise another question?
Yes. If there is a chance, I have one question, please.
Yes, go right ahead.
Thank you for this very useful information. I'm talking with you from very far away from US, from Saudi Arabia. Regarding this rare disease, I have lamin with very limited rupture.
Mm-hmm.
And I want to ask about regarding the wait and watch approach. If I'm correct, doctor said if it's very small tumors, it will not be detected with CT scan. So what if the disease spread in all small tumors, and the CT scan cannot detect it? Also, the blood tumor cannot detect. So shall we? What about the laparoscopic investigation? Should we go with the laparoscopic investigation after some time to see exactly what's happening there? Is it a good approach to go like this, or just continue with the wait and watch? Thank you very much.
No, absolutely. So I think, again, with a ruptured lamin, after an appendectomy, I think, I don't know the timing of your surgery, obviously, but, if we were to put if a camera in right now, it'd be very difficult to see anything. You would still be, you have some inflammatory response from the surgery. And again, you're not going to see the microscopic cells. So I think if you were to say, do the watch and wait, and, again, maybe at 6 months to a year's time, if you were still wondering if there's going to be anything that's developed, that may be a good window of time to say, well, maybe we can just put a laparoscope in just to see. Again, chances are if you have, 1 to 2 millimeter spots diffusely everywhere, over time, they're going to grow. So there'd be some indication at some point that maybe something is here that they could put the scope in and take a look at that point.
And would you say waiting a year or 2 or 3, is that too long in your opinion?
To put a laparoscope back in?
Yes. Right. So you said if maybe we take a look at 6 months or a year, mm-hmm. What if we waited until 2 years? Yeah. Is that too late? Right. Because this becomes that balance that no one has a definitive answer for.
Right. Exactly. So, I don't think there's a good time frame as to say when to put a scope in, but I think if, again, with the thought that, in 2 years, if there's something on your scan, well, then that's worthwhile to put a scope in. If at, 1 year, 2 years, 3 years, you're at 5 years, there's nothing on your scan and nothing has grown, nothing looks suspicious, there's no fluid. Putting a scope in you may not be, there may not be just anything there. I think if you wait long enough, I think the benefit of the laparoscopic part may be lost because clearly you as a patient have already, the biology has already deemed that nothing is developing. So I think the question to put it in at a 6 months to a year, maybe 1.5 year time frame is, well, maybe there's something there that they, because again, obviously the diagnosis was not known at the time of the surgery. So the question is, well, was there something there now knowing that it was a lamina, not just an appendicitis? I think if we wait 2 years, 5 years, whatever it may be, and there's still nothing on your scan, chances are there really may be nothing there, period, because something would have developed if something was going to develop.
And I'm glad we're taking a little more time to explore this. This is one of those trickier places to navigate a decision. So Abdul, thank you for being here. Thank you for the question. And thank you, Dr. Ongchin, for that response, for sure.
Absolutely.
Another question, if on a patient CT, there's lamina around the liver, is it reasonable to assume it's on the bowel since it would have to travel past the bowel to get to the diaphragm and liver?
Right. So I think, that's sort of the concept of there, as a surgeon who does these procedures, we take out the visible disease, but then that's the goal of the HIPEC part, that chemo part, to take care of the microscopic stuff. Because as you mentioned, there's no way to get from one spot to the other without microscopic cells kind of floating around. Again, just from just patients, anatomy and just by gravity, a lot of patients who have an appendiceal cancer, the majority of the disease normally is on that right-hand side, as well as down the pelvis, because those cancer cells kind of sit just, as you're standing, you're walking, and kind of settle down in the pelvis. So again, that's the assumption that there are microscopic cells floating around. So that is the benefit of the HIPEC, that it would take care of anything that we cannot see, with the assumption that obviously there's something there for it to get to that area.
Thank you. Can you talk a little bit about results with Signet cell?
So Signet cell is one of the pathologic findings that shows me that your cancer is a little bit more aggressive than a run-of-the-mill adenocarcinoma. And this is sort of across the board for GI cancer. So if you have, an appendiceal cancer with signet ring features, or a gastric cancer with signet ring features, it's sort of one of those things where, as a surgeon or as a pathologist, I know your cancer, when we look at the spectrum of aggressiveness from low grade to high grade, you're on the higher grade side of things. Meaning, it's going to be a much more difficult situation to cure you, because these cancer cells are just more aggressive than we'd like. So in situations like that, with signet ring of any GI sort, it's definitely something where we work with the medical oncologist. So it's usually a combination treatment approach of chemotherapy as well as surgery, because we know that these signet ring cells not only are a little bit more invasive, but they also have a higher risk of spreading to other organs, say the liver, the lungs, or things like that, where then HIPEC would not be beneficial. So then that's where we work with the medical oncologist, really treat everything. So again, we're probably a little bit more aggressive with signet ring featured cancers, because they, as a category, are more aggressive.
Thank you. Back to the ruptured appendix topic with limited mucin. If the mucin is acellular, is there only a 3% or otherwise chance that it will cause PMP?
Correct. So if it's acellular mucin, the chances of PMP are very low. So again, because there's no cellularity to really, propagate and cause PMP. Again, I think sometimes one of the things are, especially, if your pathology is read at a facility that doesn't see a lot of appendiceal pathology, I think that's where we get sometimes skewed, because, patients will come to us with this huge volume of disease, and they say, well, I was told it was acellular mucin. And then when we request the slides, maybe there was some cellularity to it. So again, when we have our patients at our tumor board, wherever our referrals are, we always ask for the slides and have them re-reviewed with our pathologist. a good percentage of patients are either upstaged or where, you know, maybe it was a lamin and it ends up being an appendiceal adenocarcinoma, where then the treatment options or treatment recommendations may change a little bit. So, but in general, if you have a ruptured appendix with limited mucin and acellular mucin, yes, the chances of PMP are probably in the single digits. But again, I would really make sure that that path is really reviewed by someone to confirm that that's the diagnosis.
And Abdul, we had Dr. Delia Cortez-Gural on this show before. She is at King Khalid University Hospital, and she is one of our experts. And so you can seek experienced advice from that hospital in Saudi Arabia.
I've got a question.
Hey, Jack, what's going on?
Hey. Not much. So to expand on Abdul's question, I'm in the same boat. I had appendix removed in April 15, so 6 years ago, partial cecum and appendix removed, 2 droplets of mucin had gotten loose. It's the histology showed no cells. I went in August for a laparoscopic investigation, found nothing. Went in, I think, in 17 or 18. You know, so 2 or 3 years later for the same thing, found nothing. I'm scheduled. My CEA's been up and down, but the last year and a half, it's been on the rise. It's up to 22.
Okay.
I'm going in Tuesday for another laparoscopic investigation, but I'm just wondering what your thoughts are on that.
Is there anything on your imaging?
No.
Nothing?
And the histology didn't show any cancer cells, but it is a mucinous whatever you call it. I can't pronounce the
Mucinous adenocarcinoma?
Yeah, I think so. I think that's it.
Gotcha. I mean, I think in a situation like that, again, and that's why we follow tumor markers as well as scans. You know, I think it is reasonable to go in and take a look. It is, you know, that is a somewhat of an unusual case because, again, as you mentioned, you've had quite a few laparoscopic procedures and there's really nothing to be seen. I don't know if you've had a PET scan. I think sometimes things that we can't see with a laparoscope are like, I think one of the questions earlier are lymph node disease. You know, adenocarcinomas, you know, similar to colon cancers, can sometimes spread to a lymph node. So if you have like a lymph node that is causing that CEA, that protein level to increase, the laparoscope alone isn't going to see that abnormal lymph node because it's sort of buried in you know, the mesenteric fat of the bowel. All you're going to see from a laparoscopic procedure is things on the surface. So I think if your laparoscopic part is still negative, it might be worthwhile getting a PET scan to see if there's something maybe in the lymph nodes that light up that's causing your CEA levels to trend upwards.
Thank you.
Sure.
Well, Adele, Dr. Ongchin, we are just about at time. I've got just enough time to once again say thank you so much for being here and thank you for sharing your advice with all of us. We really, really appreciate it. Thank you so much for a wonderful presentation.
Thanks so much for the invitation.
Yeah, you bet.
Yes,
and folks, if you have additional questions, I'm confident that Dr. Ongchin would be happy to answer them. Just send us emails and we'll refer those to her and make sure we connect the dots. Look, this is a rare disease, but there are specialists around the world. We think that education, like you've had today, is important, and we're happy to help refer you to other centers of excellence as well. So reach out, join us again next week. We'd love to be with you. And thanks for being here. PMP Palace has hope for you, and we appreciate you. Have a great week, everybody.
Thanks, everybody. Goodbye.
Thanks. Bye.